will get better.
Yeah. Just for my voice, sorry.
Okay.
Sorry in advance.
Yes. Wait a minute. It's still 35 participants. Okay. Good. Okay, Mr. Adrien, I just get the message from maybe from your partner that you cannot give the seminar full for 2 hours, but 1 hour, and then break for 15 minutes. Is it true? Yeah. Okay, it's okay. I just make sure that you.
Yes, if it's possible, yes.
Okay, it's okay.
Because I don't have my voice anymore, and I think I have just to rest and have another tea.
Yeah,
just
it's
for
okay.
10 minutes. Thanks a lot.
Yeah, it's okay, Mr. Adrien. Maybe I'm sorry. We will begin the seminar. Maybe 2 minutes left. Yes, 2 minutes. 2 minutes more, because the participant is still 43 now. Okay. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Good afternoon all. The Honorable Head of Physiotherapy Department, Dr. Bambang Tisnowianto, and Head of Diploma and Profession of Physiotherapy Department of Poltekkes, Surakarta, all lecturer, ladies and gentlemen. We will continue the seminar today. I am Herdianti Kusuma as a moderator in this session. Wait. I would like welcome to Mr. Adrien Pallot as a speaker for this session. Good afternoon, Mr. Adrien. In this session will be held for 3 hours, 2 hours for presentation and 1 hour for discussion. But because of Mr. Adrien today is not really in a good condition, so the presentation will be held for 1 hour, and then take a break for 15 minutes and then continue again. After that, continue with discussion or maybe question and answer from all participants. Okay, before we begin the seminar this afternoon, firstly, firstly, allow me to read the short bio of Mr. Adrien Pallot. He is a physiotherapist, lecturer, and also an author. He comes from France, currently teach at several education institutional in France. One of them is a lecturer in Master 2 Engineering of Rehabilitation, Disability, and Motor Performance. He is active as a writer for both journals and books, and is listed as a director of the book collection with the title Essential in Physiotherapy. In addition, he specialized in the evidence-based practice field. It is evident that Mr. Adrien is still active as a volunteer Pedro assessor for the Center for Evidence-Based Practice. And lastly, he has attended many physiotherapist conferences, maybe in around of the world. Okay, that is a short bio of Mr. Adrien, and now we can start the presentation, especially about management of physical therapy for stroke. Mr. Adrien, are you ready? Maybe firstly, can you, share the screen, yeah? For Mr. Adrien, time is yours.
Thank you very much. Can you hear me?
Yes,
Yeah,
your
thanks.
voice clearly.
Perfect. So yeah, I apologize. I have a little flu, and I will try to have my voice until the break. So yeah, today, the afternoon for you and the morning for me, we have to discuss about the stroke rehabilitation and how to do that. So first of all, I want just to thank you for the invitation today, because it's really really kind and honor for me to be invited by you. Especially I'm going back from Indonesia from the August, so I'm really proud to be here and to do some courses here for stroke. What about me? Yeah, actually, I'm physiotherapist since more than 10 years now, and I'm an author of some articles and books, only in French, actually, since 10 years too, with several colleagues of me. And I am also a lecturer in many schools in France and some in Europe too now. And since 4 years now, I'm director of a book collection, and we are writing book on every field in physiotherapy in French, but we will normally begin to it in English too next year. And actually, I am a meal lover too. And when I came here, I was so so happy, because your food is really great. And sometimes I change and I take some rice too. But yeah, I was so surprised by the taste of the food over there. So today, I'm speaking from the Eiffel Tower, because I'm in France, and we will see the stroke rehabilitation a little bit more with a French perspective, so with a French health system. So maybe it's a little bit difference between our two systems of our country. I have conflict of interest because I wrote with this kind of people the books on the pain, on neurology, and on public science, etc. So yeah, it's my conflict of interest here today. For the context now, for the stroke rehabilitation, we have to begin with the definition of the stroke. And one of the definition we can find on the WHO website, it's the sudden loss of focal brain function with no apparent cause other than a vascular cause. So that is a good definition because it's quite precise, but it's a definition inside sorry, inside the one we have a kind of idea of differential diagnosis. So if someone is with some signs of stroke, we have to diagnose the people to know if it's a real stroke or something else, maybe a vestibular disorders, maybe musculoskeletal disorders, maybe another neurologic disorders, etc., etc. And actually, when you are practicing, you can practice just in neurology, but if you practice in other field, you can be in front of this kind of patient, and you have to be aware of what is the hard signs, the red flag of a stroke. And actually, it took like very easy to do that. We have to check this kind of patient if the patient is with a loss of balance or pain in the head or with dizziness, and if he is saying that is trouble with his vision, it's one of the sign too. And he can also said or show that his face is one side dropping. So it's a big sign of stroke disease. And after that, he can have also lower limb or upper limb weakness. And with that too, speech difficulty. This is 5 signs, very important if you have this kind of signs all together or a few of them in the same patient at the moment in your clinic, because you have to call fast the emergency. In French, it's like that. So yeah, this is the kind of I don't know the term in English, but the kind of pattern, I will say that like that, pattern, red flag pattern to be conscious of that if you are in your clinic. Me, 2 times in my professional life, I had this kind of patient. One had already have a stroke, and the other one he was here for a musculoskeletal disorder, and he began a stroke just in the clinic. So we have to call the emergency, and everything would be all right for him after. But yeah, this is the 5 signs, very important to put in your head. Another context, it's the number of epidemiologies, and this is the number of women and men with stroke in millions between the year of 1990 and the year of 2013. It's really interesting because the number here is with incidence and with prevalence. So just to remember to everyone, incidence, this one is the number up, number of new cases. Donc, this is the number of new cases, and this is the prevalence, and the prevalence, it's the number, oh, sorry, I think, zoom, yeah, of cases, number of cases. So this is a little bit difference between incidence and prevalence, between the number of new cases in a year and the number of cases. Because when you see the number, it's really interesting to see the evolution of this number during year, just 33 years for the ischemic stroke and for the hemorrhagic stroke. What we have to know about that, it's the number of total population. In 1990, there is 528 billions of people in the world, and this is the number for the world. So it's good to compare. And actually, in 2013, there is 7.75 billions of people. So the increase between the two, these two number was of nearly 50%. This is a good things to know, because we have to do the same thing between 1990 and 2013. And when we do that, we saw that the incidence was increasing between the 53% and 77%, and the prevalence almost the same, no more, is increasing between 78% and 89%. And actually, if you look at this, look at this number, you see that the incidence and the prevalence increase more than the rate of the increase of the total population. So there is more stroke between, there is more stroke on 2013 than in 1990. It's really important to do that, because we have to explain maybe why there is more stroke between these 2 years. Maybe that the population is getting older, because there is evolution of the age of the death, so it's quite good. Maybe to explain the difference between that, it's they are older, but maybe we can explain that because the people are more sedentary, because maybe I don't know, the people have less primary job. It's a job like you have to work on building, work outside, and maybe more desk work job, like being in front of a desk all day long, and just in front of the computer. So you are more sedentary. So this kind of thing can explain why you have a higher incidence and prevalence of your number for the stroke. But maybe we have to know that the incidence is growing up less than the prevalence. And this is important because it means like there is not so much new cases, but there is much cases when you see your epidemiology numbers. And this is good because normally this kind of evolution of this two measure of epidemiology means like there is less death about stroke, and maybe two, better recovery because of the medication just in the onset of the disease. Maybe better recovery after, and with rehabilitation, the people can said like, okay, I don't have a stroke anymore, etc., etc. This is good things for us. because we are physiotherapists, and because actually if people have a stroke, they can have good management of that even in emergency unit. So from this this number, we can say that okay, the people have more stroke now than before. Okay, maybe we are older, maybe we are maybe more sedentary, but the prevalence is higher than the acid incidence. So we live longer with the disease than before. So it's a good point for that. Another point of context is the general public health consequences. One of the major consequences is the cause of the stroke is the cause of acquired disability in adults. This is a big issue because it costs so much money. Actually, in France and in Europe, it's sure. The second one is that the stroke is a major cause of dementia. So we have a lot of patients, inpatient in hospital with dementia following the stroke. The third consequences is the mortality. It's less concerning the rehabilitation professional, because when the patient is dead, we don't have to manage him, but it's a big cause of mortality, and we have to manage it with the prevention before that. Another consequences is that the stroke is a significant risk of recurrence after a first stroke. So when you have a first stroke, you can say that it's a risk factor to have a second one just after that. Just after that, from just after that to many years after. It's really important because we have to check the patient to manage the patient into a second prevention and try with him to reduce the risk factors for the stroke for him. One of the other consequences is the high physical dependence score of post-stroke patient. It means like we have to follow the patient long time after the stroke. So it costs money, it costs time, and sometimes we have to adapt the house, the flat of the patient. So this is really important in the health public science. And one of the most why we have all of this point, it's the important sequela of the stroke for the patient, and all of this point lead to a financial burden for every country, because it's a hard disease and with big consequences. So these points are really interesting. I'm not focusing after on the prevention, but the slide, the next slide, it's about the risk factor, and we can, we can put some rehabilitation on this kind of risk factor. For the pathophysiology, we know that there is two big type of stroke. And this kind of stroke, the first one, it's all the family of the ischemic attack. It represents nearly 80% of all the stroke. And in the ischemic attack, there is some subfamily. We have this kind of here. We have this kind of physiopathology. So we have a artery. It's not a vein. It's an artery, and in the artery, you can have some things, and this kind of things maybe we can have some cholesterol or something like that, but something will block the blood flow in your artery, and when you block the blood flow after the blockage, you don't have the flow of the blood anymore, and actually the neuron in your head have to have some nutriments, and when you have no blood flow, the neuron didn't have nutriments anymore, and there is a problem of for that, because in some minutes the neuron die of this kind of loss of nutriments. So this is the ischemic stroke. It's not the same thing than the hemorrhage one, because the hemorrhage one is the reverse. It's when the artery is explode, and it's really important because the two clinical patterns are different between the ischemic and the hemorrhage stroke. In the hemorrhage stroke, you have two big sub-family, intraparenchymal hemorrhage and subarachnoid hemorrhage. There is the two big family of that. But we have to keep in mind that when you explode an artery, it's less systematic signs or clinical signs than when you just block an artery. But we will see that in few slides. One of this kind of slide is really important, because here I put the modifiable risk factors. The slide after is the non-modifiable risk factor, because there are some risk factor not modifiable, but here it's really important, because we can act as a physiotherapist on this kind of risk factor. For example, here it's a good column, because more the number is toward plus infinity, and more the risk factor lead to the stroke. So as you can see here, this risk factor, this one and this one, maybe this one, the fourth one here are really the bigger risk factor for the stroke. And it's really good because the physiotherapist can manage the hypertension with the physical activity. The physical therapist can manage the diabetes with the physical therapy. The physiotherapist can also manage the cholesterol. We have, actually in France, we have this kind of prevention with our patient. It's to help our patient to quit smoking. So maybe it's the same in Indonesia, but in France, we can do that when you are a physiotherapist, to help people to quit smoking. And we can also promote physical activity, because it's the big core of our job. And we can also, as we can do for the smoking, we can also tell to the patient to have less consumption of alcohol. In France, it's really, I think, a bigger problem than in Indonesia, because in French, it's more common to drink alcohol. So we have to focus on that. But when you look at the number are not so high compared to the other one. And obesity, it's the same thing. We can fight against that with the physical activity and with other kind of therapy. And sleep disorders, it's the same thing. Now, the physical therapists in France are really focused on the lifestyle behaviors of the patient. So we have some question during the history of the disease with the communication of with the patient. We can ask some question on sleep, on the alcohol, or smoking, or on sedentarity of the patient. So we can manage that, because as we see that here, there is a lot of this kind of variables implicated into a stroke onset. So I think for the physical therapist, it's really important to know that we can manage this kind of risk factor, and we have to monitoring that in for the patient we have to avoid some problem. So this is the modifiable risk factor, and actually there is the non-modifiable risk factor. It's the age. So as we see, more you are older, and more you can have a stroke. Gender, it's the same with this kind of risk factor. It's not so excessive, but it's the risk factor, and the gender here, it's the male. So it's better to be a woman than a male. Sometimes, because in France we have that, sometimes people change their sex with operation, surgical operation, but actually it's not just the sex we have to change, but you have to change the hormones too, because it's the hormone which is protect you from the stroke. So the male hormone are more risk factors than the woman hormones. And actually there is some hypothesis about race, but because it's a big risk factor too, but now it's not well established if it's really the race, or maybe some confounding bias behind, because this kind of study was made in USA. So maybe it's the condition of this kind of ethnies more than the ethnies itself. So we have to focus on that on next studies to see that if there is a really ethnies a problem or not. But it could be possible to have a ethnies problem, because as we see here, heredity is a big risk factor of stroke. So if heredity is a big factor of stroke, it means like you'd have that in your DNA, and if you have that on your DNA, it could explain why some ethnies have some more stroke than others. So this is non-modifiable risk factor. So as a physiotherapist, you cannot act on that or manage that. But it's good to know, because you can predict some things for your patient on their prognosis. So to follow the pathophysiology, we have a clinical picture of the patient, so the pattern, how is touched by the pathology, and this clinical picture of the patient depends on the affected hemisphere, if it's the right or the left. It's depend on the affected area in the hemisphere, if it's touching this kind of area here, or if the stroke is touching this area or this one. because there is an organization in the brain between sensory zone or between motor zone or between cognitive zone. So when you have a stroke, you have to know, or when your patient have a stroke, you have to know where is it in the brain to know what is the pattern or the picture of the clinical script of the patient. And actually the third condition is the ischemic or hemorrhagic nature of the stroke. It's really important because actually, if I have to, I will rub it. Actually, as we know, if you have a ischemic stroke, you can just have something here, ischemic, and here something is blocking the artery. So all this artery here is without blood flow here. And if this kind of artery is without blood flow, all this zone is beginning to die. And actually, with an ischemic stroke, it's really easy to predict the clinical picture of your patient, because if you know your neuroanatomy of vessels in the brain, you can say that, oh, okay, I know this arteries is touched by the stroke, so all the tissue of the brain tissue vascularized by this artery will be deficient. So this is quite easy in the pathophysiology to predict what kind of signs and symptoms we have to see in the patient when you know about him what is the artery touched by the ischemic stroke. Actually, in the other one, in the hemorrhage stroke, it's more complicated, because in the hemorrhage stroke, you have maybe this artery here will explode. If it's exploding, it's like that. And here is not so systematic, because it's not just the zone of one artery, but it's the zone of all the surrounding beside the hemorrhage. It's really interesting and important to know that, because when you have a patient with hemorrhage stroke, it's more difficult to know the clinical picture of your patient, to predict the situation of his sign of on symptom. Sorry. For the semiology, there is a lot of semiology during a stroke, actually, because many functions are affected. The first one, I put it on the first one because it's the first function for a physical therapist. It's that the stroke will affect the movement and the cessation. The second one is the speech and the language. So it means like we need a speech therapist for the patient. The third one is eating and swallowing. I don't know if in Indonesia this part is managing by the physiotherapist. In French, eating and swallowing, the rehabilitation is done by the speech therapist, and maybe I think only the speech therapist. Maybe the occupational therapist sometimes, but especially the speech therapist. So maybe in Indonesia it's not the same. Maybe it's more the physiotherapist for that, but not in France. But it's a big problem for the patient with stroke. The first consequences is the trouble with the vision. So in French, we have a job called orthoptist. It's like a rehabilitation professional for the oculomotor dysfunction. So the patient are managed with that kind of job. We have also cognitive problem like thinking, reasoning, memories, etc. And this is managed in France by OT and by a psychologist for this kind of re-education for thinking, and sometimes too by speech therapist, but less for that. And we have also a problem of bowel and bladder control, and it's really a big problem because it can lead to infection. So we have to be vigilant for that. And after that, we have psychologicals, donc problem. Here in France, it's directly toward the psychologist. And the final one is sexual problem. Sexual problem, it's two dimension. It's a sexual problem because of the cognition, because sometimes some stroke have some part of the brain injured, and this kind of part of the brain lead the patient to more inadequate sexual behavior. When you have a frontal syndrome, you have a patient like that. And we have a second dimension of that. It's the physical problem of sex, because very often the patient are in couple, so they want to have sex, and we have to help them to do that, because it's a important part of a couple, and the problem are like the same than the patient with spinal cord injury. So the problem for erectile problem for the male patient, and some other problem for the woman. So we manage that with in France with a doctor. So a medical doctor manage that. Psychologist manage that, and physiotherapist, PT2 manage this kind of problem of this function. So many functions are affected in a stroke, and actually for the rest of the presentation, I will just focus on movement and sensation, and especially on movement, because it's the big part of the reason that physiotherapists have to take a stroke patient in management. So what else for the semiology? There is a big syndrome in semiology. It's called pyramidal syndrome. What is pyramidal syndrome? It's a lesion, or it's a problem in the corticospinal tract, in from the beginning of the tract to the end. And here the problem is in the cortex, actually, because it's a stroke. When you have a patient with a spinal cord injury, this kind of pyramidal syndrome, it's because of the spine, because the spine is broken somewhere in the step of the spine. So it's the same syndrome. And what is the signs? We have two family of signs. The first family is the negative signs. The negative signs, it's three signs. First one, it's paresis. So it's the decrease of the control motor or the voluntary motor. Or plegia. Plegia, it's the more hard paresis, because here in plegia you don't have motor control or voluntary motor control at all. So the patient cannot put his arm toward the ceiling, for example. The second sign, it's a negative one. So the patient will lose their dexterity all this kind of fine things with my finger here. The patient will lose that. And the third one is the fatigue. So the patient is really, really weak because of all the process in his head. And we have also positive signs that normally is not here if you are healthy people. It's hyperreflexia, and we have I have a video just after, we will see. Babinski's sign, it's really important. Sometimes when I do some courses in the school or in the postgraduate course, we do Babinski sign on the student, and sometimes we have a student with a little Babinski sign. So often it's just it's normal because the student is just a little bit overreacting, but sometimes it's like a pathology that the student doesn't know. So it's quite complicated when it happens in the course, in the lab course. But yeah, it happens 2 times from my beginning of course, and it's quite complicated. And the 2 times it was not a stroke. The patient have a beginning of multiple sclerosis. So it's not so funny to do a course and to come back with a diagnosis of something you didn't know. The third one is the clonus, and we will see a video just after. And one of the most important, oh sorry, I let it in French, so spasticity. It's one of the most common sign for motor disorders in stroke is the spasticity. So spasticity is a increase stretch reflex. So the stretch reflex, like myotatic stretch reflex, it's like you have to stretch your muscle, and your muscle answer by a contraction. And here it's really, 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 really increased. And there is 2 particularities. It's really increased more you are with a high velocity during your stretching of your muscle, more you have spasticity, more you have contraction. So this sign big spasticity, and the other one, it's the length of your muscle. So more your muscle is already stretched when you stretch the muscle, more the spasticity is here. And this is really, really typical because the spasticity is hypertonic muscle disorder, and there is another one called spasticity in the Parkinson disease, and this is 2 hypertonic disorders of the muscle. But the 2 patterns or the 2 pictures of this hypertonic disorder is not the same at all. So we have to be aware of that, to diagnose the patient well for that. And maybe I have a video for this kind of signs too, if you don't see it now. And after that, there is more positive signs, but we don't care for the motor part of the stroke disease. So now, just an example. I take some video from my boss. The example, if it's coming, up for the hyperreflexia. So we have a hyperreflexia sharp. So it's really, really fast. I will say that. So you will see the hyperreflexia on this kind of woman. I think it will come. Yes. So here, the left leg it's normal and the right leg is not normal. And as you see, the reflection on the right leg, it's really more lively. I will say that. This is the first point for the hyperreflexia. The second one is diffused response of the reflex. Here, as you see, I will put it again. When the doctor put his hammer on the leg, the patient answer with the reflex 2 on the right leg, but not on the left leg. So it's not normal because here the reflex here is the quadricipital reflex, so it's just on the knee. And here, when he put the armor on the right leg, even on the ankle, the patient have the reflex. So it means like the reflection, the reflex is diffused, and it's not normal at all. And the third point of this hyperreflexia is polykinetic. When you see on the right leg, I will put it in the beginning. On the right, on the right on the video here. This is just the knee with answer, and here on the other leg without shoes, it's the knee and also the ankle. So it means like there is several joints corresponding to the reflex, and it's not normal too. This is hyperreflexia. It's not specific to the stroke, it's specific to the pyramidal syndrome. But if you have that, it means like there is a problem somewhere. And if you have that on just only one part of the body, like one lower limb or not the other, it could be more the hypothesis of a stroke is more increased than other diagnosis hypothesis, because in multiple sclerosis you have that kind of hyperreflexia too. The second sign we can see is the Babinski sign. So the Babinski sign, you have to take one of you take a stick. We don't care of what stick you take, and you rub, kind of rub of the plantar side of the foot. And when you do that, normally in normal people, you have to you will flex your toes. But here, when you do that, there is no flexion of your toes. There is a stimulation of your big toe, and your big toe come up like that. I will put again the video. When you rub here, up, the toe is coming up, and this is the Babinski sign. This is a cutaneous reflex actually, and this sign problem in our pyramidal tract corticospinal way. And the third one is the clonus. The clonus is the set of involuntary and rhythmic muscular contraction, and actually for that you just have to take a limb or to take a part of the body. Here it's the foot, and the practitioners are putting the foot in a dorsiflexion a little bit fast to stretch the muscle. Here it's the triceps, and as you can see, when you do that, the patient is answering by a little rhythmic muscular contraction, and this is the clonus. And the patient can have some kind of clonus like that, even without a big stretching of the muscle. So this is the problem in semiology. After that, we can speak a little bit about the evolution of a stroke, because it's really, really important to know, okay, my patient have a stroke now and what we have to do. So now we have to see that the recovery of neurological deficiencies is enabled through two processes, one local, which is really early, and another one more lately, it's the reorganization of the central nervous system. So we have to see this kind of processes, but what we have to know too, there is two phases in the stroke. The first one, it's like first phase, with the patient is with no so much possibility of voluntary contraction of the muscles, and the second one, it's hypertonic phase, where there is more spasticity coming, and actually before we saw that, okay, the patient have spasticity, so it's not good, but actually it's a good prediction if the patient is switching from a Fox phase to a hypertonic phase, because it means like, okay, something is something recovery in the brain, so there is more spasticity, okay, but we can win or recover some contrary voluntary contraction of the muscle. So it's a good point to switch from the fast phase to a hypertonic phase. And why it's switching from one to the other? It's because of this kind of process. What it means, this process, it means like when you have a stroke, actually you have a stroke here. Here it's ischemic stroke, and there is the local lesion of the stroke, and all around there is a zone called penumbra, and this zone called penumbra is not the zone with directly the lesion, but is the zone with pushing by the lesion. So the neurons are crushed, and this crushed lead to a this process is really, really good. This process, you can have this with drugs, because some drugs like medication, not drugs like alcohol or something like that, for sure. So drugs, medication, you have some chemical things for that, and you can have that too just with the rest. So if you rest after the stroke, you can have the resorption. It's just the history of this kind of sorry, of this kind of phenomena, the edema. So it's good to have a rest and have medication if the patient have the stroke. After that, there is the decrease of the penumbra, and with the decrease of the penumbra, there is perfusion again, so blood flow again in the zone of the lesion, and as the perfusion is going up, the symptoms decrease. So increasing the blood flow means like, okay, the zone is going to function again correctly, because it's vascularized. It's a really, really good things to a stroke patient. And other things happen, other local processes. There is a reduction or lifting of diasthesis. Diasthesis, it's a big things, because actually this is the brain. It's just a circle, but it's the brain. And the brain, actually, there is some zone. So here it's like frontal zone of the brain. Here is another zone of the brain, zone 2. Here is another zone of the brain, zone 3. And actually, as you know, in neuroanatomy of the brain, I will change the color for that. Actually, there is links between the zone. So there is links because of the neurons. So there is links between zone 1 and zone 2, zone 1 and zone 3. There is links between zone 2 and zone 3, and links in the other sense, etc., etc. There is many things like that, and this kind of links depends on the neurotransmitters. This kind of links can be facilitators, so exciting the other zone, or inhibitors. But actually, if there is a stroke, if there is a stroke, I will put it in black. If there is a stroke here and this zone is no more available to function, the problem is this zone have a function on another one zone. So this function will disappear. So maybe this inhibition here from the zone 1 to the zone 3 will no longer exist. So if the zone 1 inhibits the zone 3 and the zone 1 is not available to function, the zone 3 is no more inhibited by the zone 1. And it means like the zone 3 will increase its activity. And this is the big things to know, because it means like the stroke is here, but we have a problem of a function on this kind of zone. And the diaschesis is that actually diaschesis is the phenomenon of functional inhibition of a part of the brain located at a distance of a brain damage. So this is the fact here. The fact is this zone is clearly normally in a health condition. No stroke here, but the stroke affected this zone because this zone is in link with the zone here affected, this one, by the stroke. It's really important if you want to know the evolution of your patient, but also the physiopathology, so the clinical pattern, the clinical picture of your patient just in front of you. And actually, when you when the stroke here is removing, so you can have this kind of link working again, and so the zone at the distance of the stroke can be functioning correctly. It's really an important things to know, because well, actually each time it's the process. So this kind of phenomena, diaschesis, has to we have to take it in account when you are diagnosis our patient and assess him or her, because sometimes we can make some mistakes, because we can think like, okay, I think it's the zone 3 and actually it's just the zone 1, so we have to focus on the zone 1, and after the zone 3 will become good after that. So this is a big important thing, and this phenomenon can be reversible. It's mean like, okay, you can have a stroke and have a crushed neurons, but actually after that there is some recovery possible after. For the other part of the recovery, there is the late recovery. And the late recovery is more like cerebral plasticity with the reorganization of the central nervous system, really, really important. And we have a big role inside that, because physical therapy use movement of the body to help people. And when you use your movement of your body, you use neurons for that, to doing that. And when you use neurons to doing that, you push the neurons to put some other links between them, and maybe to have some new neurons in your head. So it's really, really good things for us as a physiotherapist, that our main mean of physiotherapy, it's physical activity, lead to this kind of reorganization. So it's really, really important to know that. So we have a possibility to do more synapse and to increase the strength of the synapse. It means like, okay, more link between the two neurons. We can also have some recovery of motor skills because of the functional reorganization of the intact cortex, not just the disease cortex of by the stroke, but the intact one can also reorganize itself to produce or to give some new function lost before during the stroke. And one of the last things, it's like you can also have a bilateral activity of the motor cortex. So we can use the connection between the two hemispheres to improve the dexterity, the motor control of patient, and to help the patient to find other ways in his brain to recovery some movement for that. It's really, really important to know that, because it can be more difficult when you have some patient, like I have often for the since my first year of clinician. It's the kind of patient who has one stroke in one hemisphere, and some years after he has another stroke, so a second one, but in the other hemisphere. And it's a problem, because with a stroke, with two strokes in each hemisphere, this point it's more difficult to be used for rehabilitation. So we have to focus on that, and to avoid as much as it's possible the second stroke for a patient, with the second prevention of this kind of disease. So here it is for the evolution. And normally after that, yes, it's assessment.
Excuse me, Mr. Adrien. I think it is already 1 hour, so we have to take a break for 15 minutes, like I mentioned before.
Yeah, yes, with pleasure.
Okay, so ladies and gentlemen, now we will take a break for 15 minutes, and then we will continue the presentation from Mr. Adrien. So Mr. Adrien, you can take a break and then continue again after 15 minutes.
Thank you.
Yes. Oke, baik. Rekan-rekan semuanya, dikarenakan kondisi dari Mr. Adrien sedang tidak enak badan, sedang flu, sehingga beliau meminta untuk sesi presentasinya itu ada jeda, jadi 1 jam, kemudian 15 menit jeda, kemudian nanti dilanjutkan presentasi lagi. Oke, I wanna give information for all participants who wants to ask a question can directly or write in the chat box after the presentation, and maybe all of the participants can prepare the question from now. You can write in the chat box from now, and of course we are still take a break for 15 minutes. Okay, our break time is over. Mr. Adrien, can we continue the presentation?
Absolutely.
Okay, for Mr. Adrien, time is yours.
Sorry, I just have to share my.
Yeah, please share your screen.
So thank you very much for the break. So we will continue by after the pathophysiology and the evolution. We'll continue by the assessment of the stroke. Actually, it will be just the part of the motor physiotherapy assessment for the stroke, because there is many more assessments to do for the other practitioner. So to introduce or reintroduce this mind mapping. It's called the intentional functional classification. It's proposing a purpose, sorry, by the WHO. Actually, it's I don't know if the people know that or no, but actually you just have to put a picture of your patient and put the picture inside this kind of clinical reasoning organization. So here you have to put the health condition. So we have to put some example. It's better. Health condition. Here my patient have a stroke. Sorry for the. I don't know why I write like this, but so the patient have a stroke. This is the disorder, the health condition disorders, and my patient maybe have some impairments on function or structures, like he has spasticity. So we can put spasticity here. Spasticity. He can have speech disorders. So I have to take it in speech dis. And you have maybe cognitive disorders. So again, disorders, I put just this like that. Sorry. Activities, it's like the activities he cannot do. So maybe with the spasticity, he cannot maybe cooking. My patient cannot do that. Cannot do that because the stroke is very has very affected his arm or her arm, for example. So he cannot cook and he cannot drive. Or she cannot drive. So driving, it's difficult for the patient. So this is activities, and participation. It's all the activities with a social part. For example, if you have a stroke and you cannot sing during your shower, because during your shower you are used to sing some song, okay. In French we do that, so maybe in Indonesia too. I think it's universal. So if you cannot sing under your shower, it's not a social activity. So not singing under your shower, it's activity. But maybe you can you are a singer in in French it's choral, but I don't know is the term in English. But you can sing in a group of person who sings, like okay, the night like you play football, someone or other sing. And if you are like that, you can sing in a group of people for an event or entertainment, something like that. And this is a participation, because your singing is just not alone in your home with the shower, for example. It's with a group of people. So it's a difference between both of things. For example, if you cannot drive because you can go to the supermarket to take your stuff for you, it's activities. But if you cannot drive and you are a driver, like you are a driver in Solo, because there is so much foreigners like me with so much scare about driving in Indonesia, because we are not able to do that. We are no skills to do that in Indonesia. So but you are it's a little bit complicated, because the activity driving, actually it's your work. So it's a social participation into your life. So we have to split that between the activities, the core activity, or just the activity itself, and the participation. It's the activity inside a social part of the life. And after that, so maybe here, if the patient here, it's a driver, he cannot work because he is a driver, and he can drive, so he cannot work, and it's a big problem in the participation, because we have to know if it's okay for him. Because in France, when you cannot work after a stroke, you can have some help, financial help from the government. I don't know if in Indonesia it's the same thing or not. For example, in the USA, it's not as helpful than in France. So it depends on your health systems. Sorry. And after, you can put some environmental factors, like maybe the guy or the woman, it's the same, is married. So the guy or the woman have a wife or husband, and this is environmental factors. But we have to know for the patient, sorry, if the wife or the husband is helpful or not, because having a wife or having a husband is not always a positive thing for the patient. Some of my patients, the wife or the husband was more negative thing than the positive thing for the patient, because of all the history of the couple and how they act between them. So I'm not a sociologist in relationship, but I just have to take that in account, because maybe it's not helpful. So we have to know if the partner can help or not the patient. We have to know if the house or the flat is well organized to have a patient with some motor dysfunction or something else. So we have maybe to implement help inside the house. In France, it's really the job of the occupational therapist. I think in Indonesia too, to implement some stuffs inside the house or the flat. And we can do that with every environmental factors. So put the positive ones and the negative ones. For example, in France, when we have a stroke and you live on the 4th floor of a building without lift, so there is no lift in the building, it's more complicated when you have to go back to your home after your stroke than if you live in the house without first floor, just the main floor of your house. So this kind of environmental factor, you have to identify which is a positive one and which is a negative one. And we have the same thing with the personal factors. And the personal factors, it's concerning the risk factors. Imagine this kind of patient drink alcohol. So we drink alcohol and sorry for, I don't know why is this switching like that. I will change. Sorry, I will change and I will take the. So he drink alcohol. Oh yeah, this is better. I write with Zoom now. So he drink alcohol, he's smoking. So this is two big risk factors for stroke, but he has already one stroke. So we have to do a second prevention to avoid a second stroke. So maybe if the patient is a smoker on drink alcohol, we have to to ask him to avoid that. Sometimes it's not so easy to avoid that, so we have to manage and try with him to just reduce the consumption of the cigarettes or alcohol. Maybe the patient have low education, and low education it's often correlated with some lower type of lifestyles toward healthy lifestyle. So we have to educate the patient for that, etc., etc. So we have to take all the personal factors for that and to draw the picture of the patient. It's really interesting to use that. So this is the international classification of functioning. It's really well known in France. All the students have to learn that in the first year, and it's proposed by the WHO since this one. It's since I think 20 years, so it can help to clinical reason. So for the assessment, it's good to organize after your brain when you have the spot of the impairment, the incapacities, and etc. So if we have to continue, I just have to do that. Sorry, back now. Zoom. Try. If you have to continue, we know that the assessment of the motor part of the stroke can be assessed by several scale and tests. And I put here some different scale and tests from the stroke edge task force. It's a part of this task force. It's a part of the NeuroOpt, and the NeuroOpt, it's the neuro part of the APTA. And APTA is the Association of Physical Therapy of America, and they have some good recommendation for the stroke rehabilitation. So here I put all the scale or test recommended by these guys, and I class it by the International Classification of Functioning. So if there is a A here, it means that this test or scale is assessing an activities, and if it's a P, it's participation, and if it's a F and S, it's body function and structure. So one of the most well-known tests, because the 6 minutes world text is a test, it's this one. It's really good to do that for to know how the cardiovascular condition of the patient is, because it's really used in the studies, and we have so many documentation for the comparison with sailing threshold, with ceiling cutoff, floor cutoff of this kind of test. So it's really good to do that. The second one I want to put in this slide. It's like the little brother of the 6-minute walk test. It's the 10-meter walk. So in this test, because I have to explain, maybe not so much people know that. In the 6-minute walk test, you have two sticks on the floor, and the patient have to walk as fast as he can around these two plots, and during 6 minutes for sure, because it's written on the title, and he has to do that. And what we have to do as a assessor is to know how much meters he did. This is quite different with 10-meter walk, because 10-meter walk now it's the distance with fixed, because the patient has 10 meters to walk, and the assessor have to assess the time. So in the 6-minute walk test, the assessor have to take the distance, and in the 10-meter walk, the assessor have to take the time for the 10-meter. And the 10-meter test, it's like 10 meters, but actually you have to have 14 meters, because there is 2 meters here in the beginning to accelerate, and 2 meters here in the end to decelerate for the patient, to have actually the good speed, the normal speed for the patient between the 2 meters and the 2 meters at the beginning and at the end. So this is really interesting of test. After that, there is the ARAT, Action Research Arm Test. It's to evaluate the activities of the upper arm. Let you take the name and put it on Google, and you will find the scale and the procedure of this test. Another one is the MACE, the Modified Ashworth Scale. It's really used. Here, as you can see, it's written function and structure. Actually, it's not structure; it's function. It's the function of your patient about the spasticity. How is the spasticity? And the slide after, I will put all the scale. You will see. After that, you can have the Bear Balance Scale. This is for assessing the activity. What kind of activity? It's the balance. For me, it's one of the most interesting scale to assess the balance. There is another one called, I don't know if you do that in Indonesia, because I think it's more European creator, because there is another one, it's Tineti. It's like the competitor of Berg. So there is the Bear Balance Scale and the Tineti Scale, and who has to win. But Tineti, I think it's more European. So if you know, it's perfect. But there is some differences between them. I prefer Back Balance Scale, but actually for some people, Tineti is better, because in Tineti you have two clear parts. One, it's assessing the sitting position, and the other, it's assessing the the standing position. So there is two parts, and in the Bear Balance Scale, there is actually almost all the item is for the standing position. So if you have a stroke patient without the capacity to be able to be standing, the Bear Balance Scale will have a floor effect, and the patient will have a low, very low score on the bear balance scale, and you cannot, you won't see if the patient will improve their his sitting position or not. Compared to the TET, we have the sitting part, and you can focus on the sitting part for that. So my opinion, my recommendation for that is, if you have a patient who can stand quite good with just he can stand, even if you have to help him, you can go to the bear balance scale. If he cannot go standing, like in the beginning of the phase of the stroke, maybe TDT with the sitting part is more relevant. So but yeah, when the guy is able to stand, I prefer the bear balance scale. After that, there is the dynamic gait index. It's the index to just to assess the gait, how it is, etc. Like ARAT, you can just take the term, the name of the scale, and go to Google to see that. You can find all this kind of scale on Google. After that, there is the FIM, donc the functional independence measure. It's good. In France, actually, it's performed by occupational therapist or medical doctor. My boss does it on the patient. It's good to know how, in general, the patient is independent on the move, on how he can do activities. Even if he's in the hospital. After that, there is the functional reach test. Functional reach test, it's really easy, actually. Functional reach test, you have the patient is well, I'm physiotherapist. I'm not a drummer. So the patient is here. You see them by the profile. This is the chest, and this is the up, and the foot like that. And the patient is like that. You have to flex, to bend both upper limb and at 90 degrees, and after he has to put his body forward. And as assessor of that, we have to take the distance between the toes, the fingers at the just before the beginning, and the finger at the end of the bending forward. And we take the distance between that and that. And actually, when we have to repeat the test over the time, we have to see if this distance increase or decrease. And if it's increasing, it's good, because it means like the patient has more balance. You have to know that this functional reach test, it's included in one of the items of the bear balance scale. So if you do the bear balance scale, I think that the 11 or 12 items, it's the functional reach test. Really known, and functional reach test, sorry, it's good because is really predictive of future balance for the patient. What else? Oh, sorry. What else? The modified Ashworth scale actually comes from 0 to 4 or from 0 to 5. It depends if you put 1+ here or 2. It's just the nomenclature, so it's not very important. But you can just assess clinically the spasticity of your patient. Spasticity is the involuntary contraction of your muscle by the mass, and it's quite good because there is quite good kinematrics properties. So I always do that for my patient, and it's really clear between assessment if there is a evolution or not. So this is the scale. Normally, if you have already some stroke courses, you have learned that. To do that, it's really easy. I will draw because wow. I will draw another part of the body, and this is up. Oh la la, this is really bad. Up. On va pas faire ça. Sorry, I'm speaking in French. Up. So this is the end. So this is the end. This is here. This is the forearm, and here this is the arm, and all of here it's upper limb. So imagine the patient have apparently some spasticities on muscle here. Okay, so it's a muscle. So biceps, so brachial, so brachioradial muscles. And you have to assess that. For assessing the spasticity, it's quite easy because you have to put the forearm at the beginning of the test. You have to put the forearm in total flexion because you are assessing the flexors. So you put your forearm, the forearm of your patient in the full flexion, and after that you go in full extension. Is like that, full extension of the forearm of the elbow, and that in the Princeps description of the test, they said to you, you have to do that as fast as you can, and you have to do that during the time to said 1001, because 1001 in English, it's like when you said 1001, 1 second passed. So the test asks you to do all the range of motion in just 1 second, and to remember what is 1 second for you, you just have to say in your head, okay, I have to do that during the time I have to set 1001. In French, we have another thing, it's un Mississippi, and when you say that, it's 1 second past. So this is really important because you are during this extension here, you have to focus, you like an assessor, on the sensation you have under your hand, and the sensation you have to compare with the items here, and you have to know, okay, the sensation is these items, so the muscle, the flexor here, have a spasticity count on 2 for the mass. It's really important. The important fact is that you have to assess the range of motion slowly just before this maneuver, to avoid some problematic for the patient, because maybe he have a stroke, but he have also a musculoskeletal disorder on on his elbow. So you have to check that before. What after to continue the assessment? Sorry, we have to jump at the other list, and the other list, it's less mandatory, but there is some good things too. If you look at that, the Fugmeyer, it's quite long, like 30 minutes. There is 2 parts of that. There is a part there is the upper limb part and the lower limb part. but it's really good to assess the function of this part of the body. One more for the participation, because it's really good to don't miss the participation assessment. It's to use the stroke impact scale or the goal attainment scale. But actually, I like for me the better is the stroke impact scale, because it's really focused on the stroke. And if you want to do that, you have other thing. You have the time up and go. Time up and go, it's really easy. You have a chair, so there is a chair like that. So your patient is like that, up the chest. Oh, sorry for the patient is like that. There is a chair. There is a plot here, and between there is 3 meters. This is the rules. And you have the timer, and you time from the patient in the sitting position. He has to stand up, to go to the plot, go around, and come back and sit again. And you have to time that from sitting position to the sitting position at the end. And actually, more the time is long, less the patient is good. So you have to yeah, it's really easy to do that. Actually, if you don't have the place for a 6-minute walk test in your clinic, for example, you can go to the time up and go, because it's really well analyzed or studied in the clinimetric studies. Another things, it's this kind of scale it's another it's the competitor of Astro scale. It's the other one, and it's more complicated, because here the tardiospasticity scale, you have to take the spasticity, but you have to take the speed, so the velocity of the spasticity and the range of motion of the spasticity. So you have to take the sensation of the spasticity and also the speed, and at which angle, at which range of motion the spasticity occurs. So yeah, it's a little bit more long to do that. There is another one, I never speak about that. It's a scale for the to assess the voluntary contraction, like testing. I don't know if there is the word testing in Indonesia, but in Europe you can have a scale. It's called testing, and you can assess a muscle from 0 to 5, and so 1, 2, 3, 4, 5, and you can assess the muscle like 0, there is no contraction. 1, there is a contraction, but the contraction is too weak to move the bone. So I can contract my biceps here like that, but my forearm cannot move with this contraction. The level 2 is the fact that I can move my forearm, but it's impossible to do that against the gravity, so against the weight of my forearm. And after that, the level increased toward the 5 level, and the 5 level, it's like, okay, my muscle, it's exactly the same strength that the opposite side, if there is an opposite side, because sometimes your patient, it's with amputation or something like that. So there is this is the most strongly recommended scale and test for the, I repeat it, for the motor part of the physiotherapy assessments. So now I don't know if I take, yes, I take some other, yeah. So I will show you some of my other ancient patients. They agree to they give me agreement that I can use the video. I just crop the head, and we will see what is like motor disorders. So there is a sound. It's French. So this is the movement of the scapular thoracic joint for the flexion, and as we see, the patient here his stroke is on the right side, so it's the left part of the hemisphere, and as you can see, I ask for the flexion of the upper limb, and he tried to do that more with abduction than with flexion. So here is compensate. Is compensate the flexor weakness by the abductor muscles. Here, I ask him to do an abduction, so in the frontal plane now, and actually you can see the hypocontraction, because the movement is not the same than the opposite side. It's really clear here, and here you can see in the profile part to see how he use his trunk and his hip to do the movement. And actually, you can see another thing here, very important if you are a clinician. It's dispatch. Because this guy was a really big smoker, like more than one packet of 20 cigarettes per day. And actually, he did a stroke, and we cannot let him like smoking like that, because it could lead to so many infarctus of the cerebral part of the body. So we help him to decrease the number of cigarettes. He smoked again. He still smokes. Sorry, but he decreased the consumption of that with a patch of nicotine. I don't know the term in English, but I think it's close to. So to help him to decrease the number of cigarettes per day, and it works a lot for him. So it was so good for that. And we'll see him in other with other movement, because I spoke about loss of dexterity, c'est-à-dire loss of take something with your hand, something like a ball or something really thin. And in the in the next slide here, I ask him to take the ball by the up of the ball like that, and we'll see how he do that. It is very interesting because he tried to use the phenomenon of the flexor and extensor of his hand, and for him it was really easy to do that compared to other patients. So it was really cool to do that by the up of the ball. But actually, when I asked him to do a grip with his hand, but not by the up, but by the side of an object, it was really more difficult. So as you can see here, for him, it's more difficult. And actually, the ball was quite the same diameters than this object, and with a way beside the object, it was for him more difficult than upon the object. So we have to focus with this kind of rehabilitation. When we assess that with the difficulty of dexterity beside an object than up an object, we decide to focus the rehabilitation on this kind of task, because here it's like I have to take my glass and drink my glass, and it's really important in the life. So this is kind of task-oriented assessment. And yes, this is my favorite. This is a patient who is walking. Look at that. It was one of my first patients 10 years ago. He is walking, so he has a stroke on the left part of the brain. So he is hemiparesis at the right side, the side you see. And if you look that, you look someone is walking like that, and you want to assess the walk of your patient, and you say, okay, it's quite good. He's walking just with a stick. I like this kind of stick because it helps a lot with this kind of eye grip of the stick. And actually, when you see him, you say, okay, it's quite good for the lower limb. But one thing you have to remember, it's like the quadriceps is not an active extensor in the walking. So I will show you the same patient just 1 minute after this video for the contraction of the knee extensor. This is the same patient, this is the same knee, and I ask him, it's in French, so I translate, I ask him to straight his knee, just that. And this is how he does, how he did. So he didn't have a knee extensor actively, so impossible for him. The other side is possible, but not. So I help him, and I said, okay, hold the position now, and I raise my hand, and actually he cannot hold that. So yeah, it's really, and you can see I have no beer before. It's really important because here you can see the difference between in the ICF between a problem, an impairment on the function or in the structure, and no problem in the activity of walking. It's really important to do that because some patients have maybe impairment still many years after the stroke in the function or in the structure, but actually it doesn't affect the activity he has to do. Here it was the walking. So we have to remember that with the neurological disorder, actually for all the patients in the field of physiotherapy, but especially in the neurological disorders. So this is for the assessment part. And to finish the presentation, I put some treatment, and actually I didn't know if the people here are just undergraduate or postgraduate students, so I don't put so much explanation of what I will show. I just put the level of evidence of the treatment we can use for some of the outcomes, like to help them to help us to choose the good treatment. Before that, we have to know the 3 major principles of a post-stroke rehabilitation. It's really, really important because they are easy to introduce into the rehabilitation. The first one is to begin the earlier you can the rehabilitation of your patient. More you are earlier in your onset of the physiotherapy, the better you give chances to your patient to be better after. The second one is the intensity. More you give intensity to your patient, and more normally you solicitate, you mobilize the plasticity phenomenon inside his head. And the third one, it's processing by task-oriented exercise. Actually, if I want my patient flex his arm like that, because I want my patient to be able to take a plate in his kitchen, and the plate is overhead. So I want my patient to have this kind of skill to put the flexion of his arm quite high. I have two possibilities. I can ask my patient just to do that. Okay, flex your arm, and repeat it again because of the second point here, intensity. But I can, in the other part, ask him to do the same exercise, like, okay, you have to flex, but with like a game during the rehabilitation. It's like you have to take the plate and come back with, to put the plate in the high position and to come back with, put the plate, etc., etc. When I do that, I focus on the task, just not only a flexion of arm, but flexion of arm to reach a plate overhead. And this is really, really important, because in the brain, when you do an exercise with a task-oriented part, your activity of your brain is higher than without the task-oriented part of the exercise. So me, with all my patients with neurological disorders, I do task-oriented exercise. So in the clinic, they have, when they arrived, they have to do the coffee for everybody. It's good for everybody. So they have to do the coffee, to try to put the coffee inside the device, to put the water, to put the coffee on the little glass, and give it to the patient, the other patient after. So like a maid, but it's really, really great, because they are really exercising their habilitation to recovery with this kind of task. Here it's coffee, but I play football with others because they like football or something else, or drawing something, etc., etc. So actually, when you are giving exercise to your patient, it's really, really good to each time to put this exercise into a task-oriented dimension. So now, for the spasticity, we have some recommendation. I have to just explain the recommendation. It's really easy. When it's written here, when it's written A, it means really good. So it means like we have strong evidence, like we have to do that. B, it's middle, and C, it's low evidence. This is the how you read the table. So here it's really, really good, because for the spasticity, as we see, there is botulinum toxin. I don't know if you do that in Indonesia, but in France it's really, really common for that. It's a medical doctor who do that. And what is good, it's to see that there is many and here too, many recommendation toward the fact that you have to modify I don't know the term in English, but to modify the joint between the muscle and the neuron, because it's here that the toxin worked between the neuron, comes to the muscle, and when you put the toxin, like to avoid riddle on the face, you can have a patient with less spasticity after. So it's really, really good. You can have the same thing before that, because me, now I'm quite old, but before the botulinum toxin, my patient took some oral medication. It was actually the same process for the phenomenon behind, and it was quite good too. What is good because this four procedure is not rehabilitation. Actually, it's by a medical doctor, so we have to focus on what we can do as physiotherapists, and we can do here electrostimulation or vibration. So it's really good because it's evidence, but we have to know that it's just an addition of other part of rehabilitation, because it's not it couldn't be the core of your rehabilitation. And after that, you can also try to avoid maybe the splints and the taping for the prevention of some spasticity, because actually it doesn't work so much for that. So we have to take it in order, because me, with so much patient, I put splints or taping, and actually it doesn't work so well, except when there is some I don't know the term in English. I think tendinotomy. So the surgeon cut the tendon of the muscle when there is so much spasticity, and put some increase the length of the muscle. And when the surgeon does that, it's interesting to put splints to keep the muscle with a bigger length of the muscles for the patient. So it depends on what we have to do for that. But actually, you can put a splint for so many years, and the patient we have the same spasticity after that. So we have to think about the relevance of that. After the spasticity, we can also try to rehabilitate the balance. And the balance, there is high evidence of our job for that. So it's really, really good for us because actually, if the patient have a poor balance and we provide a good balance training, it could really helps the patient to the risk of falling. And it's a big things to avoid. And actually, it's the same thing. It's if you see that the patient is not so balanced because of some spasticity, you can use ear orthosis or assistive device. In French, there is a orthosis for the foot, because the foot is commonly affected by the stroke. And actually, you have the leg like that, the foot like that, and we have a device. We put the things around the anterior part of the foot, and there is an elastic here, and here another attach on the leg, and this is an elastic. It's made for, so it's a strong elastic, and it's really, really good, because when the patient put his foot up, the elastic help to put the foot in the flexion, dorsiflexion, so you can avoid this kind of foot in this position because of the spasticity of the muscle here, the triceps. So it's a good orthosis. It helps a lot the patient, especially the patient with the spasticity on the extensor of the foot. So voila for the treatment like that here. After that, we can have. Oh, sorry. After that, we can have also treatment for here the mobility. So the mobility is the general term for that. And as you can see, you have a big A with a big one level of evidence that intensive, repetitive, task-oriented exercise is really good for at least the gait recovery. So this word, intensive, repetitive, and task-oriented training, it's really the 3 words to remember after this presentation, because actually it's the 3 principles. If you have that in the head, you can be so creative with your exercise after with your patient. One other thing, it's a group therapy with circuit training. I like circuit training. It's like like CrossFit training. You put some workshop in the circuit, and the patient have to do all the workshop and to try to do the exercise inside the workshop. It can be for walking, for reaching something with the head, etc., etc. After that, it's really good to be focused too on the cardiovascular exercise, and it's good because the cardiovascular exercise can help to recover the stroke, but also to prevent some other risk factors for second stroke, like hypertension, like cholesterol, etc., etc. So it's really good. It's the same thing. You can use electrical stimulation for the foot drop. Normally, it's called in French. It's stimulation. In English, I think it's functional electrical stimulation. So you can stimulate the weak muscles in the foot, like anterior tibial muscles, to avoid the foot drop during the walk. After that, you can also put your patient on a treadmill. It's really good. And if it's not possible for him, try to have body support for the patient. So it's quite expensive in France. It's really expensive. So it's more for the hospital or for the rehabilitation center. Exactly the same for the robo-assisted movement. But as you can see, you can do some really good rehabilitation just with your hand and with creative exercise, and you don't need so much super devices, really really expensive. So it's really good to know that, like that. Okay, just with a good area, I can do many things for my patient. So this is for mobility, and this is the principal aspect of the rehabilitation. And actually, I think it's yes, it's the last one.
Yes, I'm sorry, Mr. Adrien, we have a limited time, so you have 2 minutes left.
Okay, perfect. It's the end. And actually, for all the upper activity, what is good for that, and you could read that after, because I will send you the PDF. It's like, okay, you can do some activity, some recovery of your upper extremity activity with simple creative exercise, and it's well assessed by the studies now. So you don't have You don't need some big robot or big things like that, but it's better if you have one, but you can do that without. And one focus I want to do for the last minute, it's constraint induced movement therapy. Constraints induced movement therapy is that the patient, if his right arm is with hemiplegia, you will fix the left one. Fix it's you put a splint or you put a belt under his left arm, and you ask your patient during as long as he can during the day to just use his impaired limb. It's really, really good. It's called constraint induced movement therapy. The negative part is that the patient must have some little level of voluntary contraction, for sure. If it's a flask part of the stroke, it's not relevant for that, but it's really, really good for the rehabilitation. Like that, you just have to focus only on the impaired limb, and you can do exactly the same with the lower limb, with weight on the else part of the body. So voila, it was the next slide for the mobility. And I thank you everybody to be there and to listen me even with my voice today. Sorry for that again.
Okay, yeah. Thank you for thank you, Mr. Adrien, for the presentation. That was I think it was a good presentation, and the presentation is really informative and also comprehensive, I think. So now we continue to the next session, that is a question and answer or discussion session. So for all participants who want to ask the question, please, you can raise your hand. You can directly ask to the Mr. Adrien, or you can write in the chat box, please. Yes, Ni Putusanti Agustini. Please ask question to Mr. Adrien.
Thank you for the opportunity, and thank you, Mr. Adrien, for your explanation and your sharing of your knowledge. I'm a little bit curious, and I have some question for you. So the first time you explanation about the risk factor of the stroke, and you also explain it like the biggest risk factor of stroke in your country, basically. I have been see a stroke patient in Japan as well before, and the risk factor is quite similar. So the first question is like, how old the youngest stroke that you have met so far in Europe? And the second is like for the sleep disorder, what a treatment that you give to the stroke patient?
Thank you very much for for your question. The first one was how old?
Like how old the youngest stroke patient like in Europe, because in Japan, even like the risk factor of the stroke is quite similar with the European, but the population in Japan is like the elderly people is more maybe compared with European.
Yeah, it's a really good question. For sure. The number here was from a study who is looking all around the world. So it's the mean of the risk factor. So maybe there is some heterogeneous number inter countries, and we didn't know about that. But me, the younger patient I has is I have was babies because they stroke as a baby, not cerebral palsy, but stroke as a baby. But for a normal adult stroke, my patient, the younger, was like after the teenager, like a young adult, but it was because there are some hereditary disease. It's like many little, I don't know the term in English, little bubble in the artery, and they just wait to explode. explode. So it was not a real risk factor about the one I present, but actually the mean age in France, it's like 60, 70, the age of the stroke, and we consider in French like it's young if you have 40, 50 years. It's young for us. But there is more people like that now. And we are looking for the consequences of the COVID, because everybody during 1 year and a half in France was in the sofa. So sedentarity and with some stress, because it was so stressful, because no job, the money, not allowed to be outside with friends. And so we will see for that too, because maybe we will have high um, high coefficient on the curve in many years for that. But yes, in France it's like 40, 15. It's young for the patient, really young. And for the second question, it's how you can handle the sleeping disorders. Yeah, but it's pretty it's hard. Actually, with the patient we ask how many times they sleep, and if these times it's coherent with them, because if the patient say I sleep just only 5 hours per day, and for me it's cool, I'm not weak or with fatigue, it's okay. But if not, we can make some behavior therapy. So we follow him to do better sleeping, like a planning, like physical activity, like a planning. Like each day you have to work how many hours you sleep, why you are not sleeping. Is it stress? Is it other thing? We ask about some couple problems, because sometimes it's because it's not good with the wife or husband because so many years together, or with children, or with parents, or something like that. But we have to ask about the surrounding and the environment, and try to case by case to correct it. And if it's not sufficient, we can ask the patient to go to the psychologist if it's a psychology problem, or in the medical doctor if he has some apnea during the sleep, etc., etc.
Okay.
There is no one size fit all therapy.
Okay. Because sometimes I give for a people with a sleep disorder with yoga nidra, because it's quite common in Bali with a yoga, but I never try it with stroke people. So the last question is, because the before you finish, you have been explained about the level of evidence and the class as well. And before I take this class again, like before I just read all of the journal with randomized control trial with a critical appraisal. I mean, I feels like that's already good enough to read and to update the knowledge. But now I just know if we need to do the critical appraisal. But you say before, the level of evidence is A, and the class is 1, is like a big level of evidence. Like how we know the class is 1, and is it the level of evidence A is a systematic review or what?
Wow,
Thank you.
this is a really big question, and actually, thank you very much for this question, because it's this is my expertise, this kind of question. So I'm not afraid of that. There is 2 dimensions. There is normally the level. Sorry for the of evidence, and the level of evidence, it's from 1 to 4 or 5. It depends on what scale you use. And in regard of that, you have the level of recommendation. Oh la la, this is worse. Sorry. Level of recommendation, and this level comes from A to C, and actually there is just a link. The 1 here give a, the 2 and 3 give a B, and the 4 and 5, if 5 exists, give a C. And if so, this you have to do the critical appraisal of your article. And if there is no article, there is expert opinion. So it's possible to have expert opinion, but expert opinion, it's just opinion. So it's not a fact, actually. So it's the lower level of that. If I said, okay, for stroke rehabilitation, you have to do that, and I have no article to argument this is at maximum, it's expert opinion, but is not higher than that. So you can counter argument my opinion with a good justification if you have a RCT. So expert opinion, normally you call it, it's lower than C, but you can use that. But so this is the link between the level of evidence and the level of recommendation. But your question is how I can put 1 or 2 or 3. And this question is really good question. I can answer it at all here because it's 20 hours of work. But yes, you have to do that. You have to know which question you have. If it's a etiology question is like smoking give the stroke. It's if it's a diagnosis question it's like is the Lachman maneuver for the knee is assess well a tear of my ACL. You can have therapy question. Therapy question is like, okay, virtual therapy is good for a stroke or not. And you have also prognosis question, blah, blah, blah. There is a lot of, this is the step of your situation, clinical situation. And when you know where you are, so maybe for the stroke, when I show the level of evidence, it was for therapy question. And these therapy questions have hierarchy of level of evidence. And the hierarchy is meta-analysis, after a systematic review, after randomized controlled trials, and more you are down and less level of evidence. So when you know that you are with a therapy question, is kinesiotaping is good for tendinopathy, for example, and you have to look at the highest level, so meta-analysis. But maybe there is no meta-analysis, so you have to just take RCT. So you take RCT and you have to check the quality of the RCT. So you have to put a scale to assess, sorry, the critical part of RCT. And there is two big scale, Pedro scale, done just close to you because it's Australian scale, and Rob scale, the risk of bias tool. And this scale is from the Cochrane organization. And this scale help the lecturer, the reader, to know if the RCT you are reading, it's a good RCT or not. If it's a good RCT, and RCT it's a good for therapy question, so you can say, okay, it's a level 1 or 2 for the evidence. So a big recommendation to do in practice. But it's there is some tricks. It's more complicated than that. But this is the general overview of your question.
Thank you very much.
Okay. Thank you, Niputu Santi Agustini. I think that is what is it? A big question. Maybe Mr. Adrien not have a lot of time to explain all the question or to answer all the question. Okay. Maybe other participant want ask a question to Mr. Adrien, please. Okay, there is Mr. Shakur. Please, Mr. Shakur, ask the question.
All right, thank you very much for the time it's given to me. Okay, Mr. Adrien, can I ask you about what have you told to us? Treatment on posture rehabilitation earlier has better and higher intensity. It's a better
I'm sorry. Can you repeat the question because there is noisy.
Yeah, that's too noisy over here because I'm okay. So just move to it. And earlier treatment on the posture has a good chance to get healthier, and the higher the intensity has better as well. Can you describe to us the minimum and the maximum load by the treatment on posture divided by its most acute until the chronic? Thank you.
Okay. Can you get the question, Mr. Adrien?
I think I don't have 3 words inside the question. If it's possible to write it, it's about early rehabilitation and the load of exercise during this phase.
Oh yeah, sorry. Maybe I can tell. Can you describe to us about the minimum and the maximum of intensity treatment on the posture divided by its most acute until the most chronic stroke?
Okay.
Post-stroke.
Yeah. Yes. You want like a guide of which intensity I can give to a patient from just the post-stroke early phase to the chronic phase. That.
And yes, also yes. The minimum and maximum intensity. Yes.
Yeah. Actually, it's a really good question because just after my diploma, I was like, okay, I want numbers. I want to know how much I can give to sorry, to my patient, etc. And actually now, maybe just in Europe, in France for sure, but in Europe, but now it's you are not driving by a number for everybody. So my opinion and what I do in the clinic, it's for the motor part of the rehabilitation, I assess the patient with a scale of 0, no contraction, to 5, the same contraction than the opposite side, but if it's healthy side. And actually, if the patient is 2, so 2, it's for one function of muscle, because maybe it's 2 on this scale for the flexor of the shoulder, but maybe it's 5 for the extension of the shoulder. So I have to cut all the function of all the affected part of the body of my patient. And if it's 2, for me, this number lead my proposal of exercise, lead it to come to 5. And what it lead it to in parallel, it's all the compensation the patient can have to do the exercise. So if I saw the patient use the motor function with a 2 level of motor strength, but without compensation, I will ask him to continue. But if he's with really big compensation, I will ask him to avoid compensation. This kind of principle, I keep it more for the first part, like acute phase, because in the chronic phase, I let the patient with more compensation to reach the better strength of his muscle. So I don't have like, okay, minimum or maximum. Minimum for sure, it's at least 2 for my patient. If my patient have 2 points on the strength scale, I want the patient use these 2 strengths. If it's if he's using 1 level of strength, whereas he can do it at 2, I will ask him to do 2, because one of the principles of my rehabilitation is intensity. So I want him to do at least the intensity he can do. But the maximum, it depends. I want the maximum, so I will ask him to be above the maximum he has during my assessment with the patient. But sometimes, some days, it's not good for him because he is weak, because not good sleep, or maybe a little bit depressed, something like that. So I have to adapt. But there is no maximum, actually, just better or more than he has. And for the motor strength is like that, but for me, for the other part of the rehabilitation for stroke, it's like that. Actually, my patient is at this level, and each time I just want to do exercise at a little step level above, and like that I can have a rehabilitation step by step, and really adaptative for the patient. But I don't have I don't have a number to give you, because I think it's more complicated with a number. But for the minimum, for sure, it's the minimum he can do that. If he can, if he cannot, okay. So we stop the rehabilitation session, and after, sorry, I'm speaking French, and after he could come back tomorrow on the day after. In French now it's like that, but we can use some grip dynamometer or some dynamometer with accurate number, but why it's not so useful finally, because neurology, it's function, it's not sport therapy. I don't know if I answered your question.
Okay. how about Mr. Shakur? Is it enough?
Yeah, thank you very much. I got it. Okay, thank you, Mr. Adrien.
Okay. Yes, thank you for the answer, Mr. Adrien. Okay, I think a lot of participants. I think some of participants still have a question, but because our time is limited, so I think for today's seminar is enough. I would like to say thank you so much. Thank you very much to Mr. Adrien Pallot for the presentation, and to all participants for the attending this seminar today. But before we end the seminar, maybe we have to take a picture before leave the Zoom meeting. So for all participants, please to open the camera. And this is there is a 3-part in Zoom meeting. So I will give a sign to get ready. All right, please open the camera for all participants. Okay. I will take picture 3 times. Okay. 1, 2, 3. Again. 1, 2, 3. And once more. 1, 2, 3. Okay. Thank you for all participants for attending the seminar today. And maybe we have to close the seminar. For me, I said Assalamualaikum warahmatullahi wabarakatuh. Once again, thank you very much, Mr. Adrien, and all participants.
Thank you very much, Mr. Adrien, for being a guest lecturer. Do you remember me?
Okay.
Terima kasih for the invitation.
Oh yeah, sama-sama.
Yeah, sama-sama.
You're welcome.
I learned this term.
Yeah, I read your in first slide.
Yeah, my first.
You only
Yeah.
said terima kasih.
Yeah, terima
Thank
kasih.
you.
Sama-sama.
See you later. Nice to meet you, Mr. Adrien.
Yeah, with really good pleasure. And if there is some other question, you can all send me by email in one email, and I can answer that one by one. And I send you back the email with the PDF of the presentation for everybody for sure. I can do that this weekend because now I'm again ill. I will
Okay.
not have energy.
I hope
Thank you very much.
Get better, Mr. Adrien.
Yeah.
Okay, you can leave the Zoom meeting.
Bye bye.
Yeah, bye.